Welcome to today's video. Thank you for coming as always. Now, it's a bit of an international update today, but we want to focus on Africa because there's some apparently remarkably good news. It looks like the infection fatality rate is really quite low. Some studies have shown it's about 8 times lower than we would expect in the US or the UK or Europe. Other studies have shown it's more 100 or several hundred times lower. So quite what's going on here. This is in mostly countries in sub-Saharan Africa. But having said that, the infection fatality rate in South Africa seems to be comparable with Western countries. So there seems to be this divide going on between the rest of the world and some African countries. And South Africa seems to be sort of grouped in with the other Western countries. So it's a bit hard to tell what's going on, but I'm pretty sure, given the data we've got so far, this is remarkably good news. And a lot fewer people are going to die in Africa than I had feared, and certainly the World Health Organization had feared. I mean, Mike Ryan just the other week was saying that the rest of Africa is probably going to go the same way as South Africa. Now, it looks like that may not be the case. And if so, this is remarkably good news. Now, just to skip to the bottom lines here, we've known that the population in African countries are very often lower than in Western countries. But we feared because of comorbidities like malaria and HIV, that might compensate and the death rates might be comparable. But it looks like my thinking on that was not accurate. It looks like I was wrong on that, actually. It looks like the more youthful age in African countries is more than compensating for the burden of morbidity that's already there. So that's kind of the bottom line. It looks like really good news. And, I had feared millions of deaths in Africa. Now, we still don't know for sure. There's going to be more studies coming out. There's a big French study coming out in October. We're going to know more for sure. But so far, it's remarkably encouraging. So that's what this video is about, and we will be presenting evidence as always. So do stick with us. I'll be here, and I would love to have you along. This is affecting some of the poorest people in the world, and I think it's remarkably important. So low mortality and morbidity in Africa. So less morbidity, less deaths, and the mortality seems to be lower as well. People do not seem to be getting as sick in the same proportions and in the same percentages we would expect people to get sick in other Western countries for which we already have reasonably complete data. So that article there is in an African Science magazine. It seems to be a remarkably good one. Do read it for yourself. But of course, I've gone back to the original papers. Now, the first paper is that seroprevalence of anti-SARS coronavirus 2 immunoglobulin G antibodies. So the IgG are the antibodies that last for longer. And this is in Kenyan blood donors. Now, this is not peer-reviewed yet. It's published as a preprint, but it's not from a Mickey Mouse University. This is a collaboration between the Kenya Medical Research Institute, the Wellcome Trust, and the London School of Hygiene and Tropical Medicine, no less. So this is done by very reputed academics in the field, and do read it for yourself. As always, the references are there. Just click on it, it'll take you straight to it. Now, the method that they used in this study, they were measuring immunoglobulin type G prevalence. So Ig, immunoglobulin, type G, these are the longer lasting ones. And immunoglobulins, of course, are antibodies. So basically it's saying it's measuring antibodies to the SARS coronavirus 2. Blood samples were taken from the 30th of June up to the 16th of, from the 30th of April through to the 16th of June. So blood samples taken all through May and the first half of June 2020. Now, a count was taken of the non-random sampling. Now, what do we mean by this? Well, in order to get results that we can extrapolate to fairly large groups of people, we have to have a random sample so it's representative. But of course, blood donors might not necessarily be a random sample. So the researchers were able to use statistical techniques to account for the fact that this sample was not as random as you would like it to be if you were doing a prospective clinical trial. But still, let's see what they did. Let's see what they got. First thing to notice is it's on a fairly large sample. So the sample was good. There was 3,098 donors were for whom full data was available that they were able to use. Now, they actually collected blood from about 3,500 donors, but they didn't have full data available on all of them. So they still ended up with a sample of well over 3,000. Now, that is a good-sized sample. If you recruit 3,000 people for your research project, you're normally doing fairly well. It's a good-sized sample. The age ranges were 15 to 64. And the crude overall seroprevalence, that is sero is the serum. So as you know, in blood you have plasma, and you have cells. So your blood is probably something like, if you're a man, 45% cells, 55% plasma. But the serum is what you get when you spin it down in the lab. So what you do is you take the blood, you let it clot, you then put it in a centrifuge, you spin it down. That spins down the red cells to the bottom because they're heavier, and the serum is the part that remains on the top. And that's where the antibodies are. They're in the serum. So the seroprevalence, that's the amount of antibodies in the serum in people, was 5.6%. So 5.6% of these blood donors in Kenya had been exposed to SARS coronavirus 2 in the past month or two. Because it's important to remember with antibodies, when we're looking at antibody studies, now the IgM comes first. That doesn't last for as long, and the IgG lasts for longer, but it only lasts for 2 or 3 months. And some people don't even make the IgG. They seem to have the infection, but they don't have detectable levels of IgG. And in other people, it can fade fairly quickly. So when you do sero studies, you're always underestimating the amount of people that have actually had the infection. But nevertheless, they still found it was 5.6%. And then when they adjusted for things like inaccuracy of testing, it ended up at 5.2%. So 5.2% of people who were giving blood had been exposed to SARS coronavirus 2. And the seroprevalence was highest in the urban communities. So Mombasa, Nairobi, Kisumu. And this is a pattern throughout Africa. We'll see this in all the studies, that the prevalence is higher in the cities than in the rural areas. So the pandemic has spread through Africa via its cities and is now only percolating out into the rural areas now, it would appear. Although it's hard to tell because the amount of data from rural areas is very limited. But it does seem to have spread from city to city and now percolating into the countryside. So this is from the prevalence was highest in these 3 city areas. And of course, these are in different parts of widely different parts of Kenya. So it's kind of all over the place. So I mean, you've got Nairobi, which is the capital. I'm not sure where Kisumu is, but Mombasa's way down on the coast. It's hundreds of miles away. So this is spread out all over Kenya. Interesting to remember the Kenyan population is 52 million. Now, what do we conclude from this high seroprevalence in Kenya? Because it's estimated that about 1 in 20 adults in Kenya had SARS coronavirus 2 antibodies during the period. Now, so that was about 5%, 5.2%. But given the fact that some people didn't make antibodies, that could easily be, 7.2%. Given the fact that some antibodies already faded, that could be, that could be 9.2%. We don't know. Whatever, this 5.2% is always going to be an underestimate of the number of people that were actually infected so far. So we see the virus has spread quite widely through different cities in Kenya. Now, at the time, the median date of the survey, the middle of the survey, in Kenya, they were officially reporting 2,093 cases with 71 fatalities. Now, this is based on antigen testing, so it's going to be a massive underestimate. But the Kenyan nurses and doctors are just as capable of recognising death as we are, that's for sure. I've worked with Kenyan medical staff, and the ones I work with, I must say, were excellent, very good quality clinicians. And that gives an infection fatality rate of 0.0026%. Incredibly low case fatality rate, because we know that number's an underestimate. So this infection fatality rate is 100 times smaller than we might expect in massively less. I mean, if this is accurate, and it does appear to be, this is phenomenally good news. Millions less people in Africa are going to die than I had feared. I really hope this is right. And it's supported because hospitals are not reporting many COVID admissions. And yet, perhaps between 5 and 10% of the population has had the infection. So we've got a massive amount of people in Kenya who have been infected, but not many of them were getting sick because the hospitals weren't inundated, as we've seen in Europe and the United States. And not many of them were dying. So lots of people infected, very few hospitalised, very few deaths. Now, of course, there's going to be some deaths from COVID-19 that weren't recognised. There's going to be some. But there's not the excess mortality overall in Kenya that we've seen in other countries or that we've seen in South Africa. So this data is suggesting that the infection fatality rate in Kenya could well be 0.002%. I mean, it's just incredibly good news. And the study authors note that it's several orders of magnitude different from what we would expect from a Western country with similar levels of infection. So on the face of that, remarkably good news. And I don't see an obvious reason why that is not accurate at the moment. Let's have another study. High SARS coronavirus 2 seroprevalence in healthcare workers, but relatively low number of deaths in urban Malawi. So low-income countries, public health measures are difficult, socio-economic reasons, constraints, therefore potential rapid spread of the severe pandemic. So in other words, we've said this many times. In a lot of these poorer countries, what you eat that day is what you eat that night is what you earn that day. Locking down is just not possible without starvation. Therefore, you would expect that the pandemic would spread like wildfire and you'd have lots of people sick all at the same time with lots of people dying. That's what you might anticipate based on data from Western countries. That's what you might expect. But what do we actually see in Malawi? Picture so far, difficult to assess, low levels of testing. Okay, fair enough. So that's our proviso. But SARS coronavirus 2 sero-survey amongst healthcare workers in Blantyre, which is one of the big cities in Malawi, to estimate the cumulative indices of infection. Now, to be fair, it won't estimate the cumulative indices of infection. It will just indicate who's had the infection over the past couple of months. Now, the T-cell immunity is going to last much longer than the antibody immunity. So what we're desperate for, if there's any serious boffin-type scientists listening, we really need a simple test that tests for T-cell immunity. Now, I know quite a few people are working on it, so that will come, but it's not readily available yet. But that would be great because that would tell us who's had the infection at any time since the start of the pandemic. But we haven't got that, so we have to make do with the immunoglobulin type Gs, which just tells us about the past month or 2 months or at most probably 3 months. So it's not really a cumulative index, but I can see what they're getting at. Now, what happened here was they tested 500 otherwise asymptomatic healthcare workers from Blantyre. So a good sample size, 22nd of May to the 19th of June. Serum samples were collected from all 500 healthcare workers. So a good size sample, 500 is quite an acceptable size sample. Now, the results. 84 participants tested positive out of the 500. So 84 were positive out of 500. That's quite a lot. It's quite a big sample size. And quite a lot of seroprevalence. In fact, it's 12.3%. That's quite high. And of course, as we've looked at before, 12.3% is the minimum because some don't seroconvert and some the antibodies are going to fade. So it's at least 12.3%. And interestingly, they were from different parts of the city, so it wasn't representing a cluster. This is from all over the city of Blantyre. Suggests that local transmission was high and the virus may have been circulating for some time in Blantyre. So this high seroprevalence rate amongst healthcare workers means This has been around for a while. And this, of course, has been quite a bit of a mystery, really. You know, the virus seemed to be spreading around the world. And you think, well, where are all the cases in Africa? Was it just because they're not testing? Well, yeah, it is because they're not testing, but it's also because people don't seem to be getting sick and don't seem to be dying at anything like, as we saw before, orders of magnitude less than in Western countries. Anyway, these authors are concluding, and this wasn't a Mickey Mouse study either. Where was this one? This one was from Malawi, Liverpool. So Wellcome Trust again financing. Malawi universities and Liverpool. I think this was the Liverpool University in collaboration with the Liverpool School of Tropical Medicine and Health, which I did a short course there myself. Excellent institution, absolutely world-class institution. So again, these are not Mickey Mouse studies. Again, not published, not peer-reviewed, but that takes time. But very reputable people carrying out these studies. So the virus had been circulating for some time, using age-stratified infection fatality estimates from other places. So they looked at the age of the people that were getting infected and the age of the people that were getting sick, and they compared that with similar age groups in Western countries. So this is even comparing people with similar ages. They estimated that in Western countries there's 8 times more deaths. Now, this is not as simple as saying that less people in Malawi, and Blantyre in this case, are dying because the population of Blantyre is younger. Well, the population of Blantyre is younger than, say, the population of New York, but that's not what's causing the greatly reduced death rate in Blantyre, because that was taken account of. And they still found it was 8 times less people dying than should have died. So in Kenya, we saw hundreds of times less people dying overall. But here, even accounting for age, comparing people of the same age, the death rates were still 8 times less than would be expected. This is incredibly good news. And of course, the population of Malawi overall is much younger than the population of the United States. So that's going to be massively protective as well for the population as a whole. Reported number of deaths in Blantyre at the time was 17. Now, extrapolating that to the country, comparing it to the United States or the UK or Spain or Italy, you would have expected 5,295 deaths. In actual fact, there was 51. Quite incredible. Quite incredible. It's almost like we're talking about a different disease, and we'll talk about that later, but we're not. But the differences are phenomenal, and this is remarkably good news for the African situation. So the conclusion from this study in Malawi, high seroprevalence, obviously, discrepancy in the predicted versus reported deaths, obviously, massive discrepancy. And there's been an early exposure but slow progression of COVID-19 epidemic in urban Malawi. So it's been there for much longer than we'd thought, but it seems to have progressed slowly. So this is another really good news story. Now, just 2 more briefly, just to ram home this point. Mozambique. This was a study of 10,000 people in 2 cities. Antibodies were 3 to 10%. Averaging about 5%, again similar to Kenya. Market vendors and health workers had the highest proportion of antibodies, as you would expect, and Mozambique only has 16 confirmed deaths. So again, phenomenally low death rate. Phenomenally low. Cameroon, unpublished data but reported from a bacteriologist working with Doctors Without Borders, so reputable clinician, reporting similar low figures from another sub-Saharan African country. So this is perhaps the most profound video I've made in this series. This is incredible. Is it like 100 or 1,000-fold less people dying in Africa than in the Western countries? It's starting to look like that. And of course, the implications for this are huge. Firstly, it's wonderful for Africa. But next we need to go flat out to understand this. So whatever is going right in Africa, we need to make that go right in England and in Scotland and in America and in France and everywhere. You know, if there's some thing that is protecting the population of Africa from illness and death, then we want to know what it is, because we want everyone to have it. We want everyone to have this. So this should really, in my view, be a major priority for research. Why are these death rates so low? What can we learn? How can we apply that to our situation and get our death rates down to 0.0026% infection fatality rate based on those calculations in Kenya. We'll have some of that. Let's work out what it is. So much we can learn from each other here. Now, explanations. This is partly me thinking out loud, partly from the authors. So Africa misses more cases due to reduced antigen testing. So first of all, some of this effect could be that they're simply not testing. Unfortunately, there's not enough testing going on. So we could just be missing a trick. So Kenya, for example, is testing 10% of what Spain and Canada are testing. Nigeria is testing about 2% as much as Spain and Canada are testing. So we need to get lots more tests to Africa, even if that's only through enlightened self-interest, so that we can learn what's going on in Africa so we can benefit from it. And hopefully save many African lives as well. But the point is, Kenya does not have an overall rise in mortality. Now, the death correlation figures in Kenya are pretty good, and Kenya does not seem to have an overall rise in mortality. And if you look at the reference above, that's supported by, as well as supported by government figures, it's also supported by a local pathologist who should know about these things. They are not seeing more deaths than they expect in Kenya. But strangely, this is strange, South Africa is. Excess natural deaths in South Africa are 4 times the COVID death figures. So what we're saying in South Africa is the increase in overall mortality is about 4 times the official reported COVID death rate based on a 5-year average of the amount of deaths we'd expect this time of year. So we believe, as we've looked at in previous videos, that South Africa is greatly underreporting. And yet these other African countries, which don't have the excessive mortality, but do have the high seroprevalence. Now, South Africa, so South Africa's got higher deaths. Don't take my word for it. Look at it there. But it's even higher than they're claiming. Now, one explanation, of course, is going to be age. But from the Malawi study, we show that that doesn't completely explain it. It's going to explain the huge differences in Kenya. The 0.002 infection fatality rate in Kenya will be partly explained by that. But the Malawi data is not explained by that. This is absolutely intriguing. And if we could get to the bottom of this, we can save potentially a lot of lives. We really are missing a trick here with these the lack of international comparisons that are being done, which is why I think this video is important. I hope you're still with it. I know it's quite complicated. Now, median ages, the median age. So that's the one in the middle of the median, isn't it? So Spain, it's 45. Italy, it's a whacking 47. UK, it's 40.5. Now, the United States is a bit difficult to tell because every state is reported separately. But overall, it's round about the same. So the US is going to be round about 40 years of age as the median age in the United States. Give or take a couple of years, I would have thought. I'm open to being corrected on that, but it's not far off. Kenya, the median age is 20. Malawi, the median age is 18. Now, that is profound in itself. Of course, that means that lots of people in Kenya that should have grown old and lots of people in Malawi that should have grown old are dead already. Why isn't there an international outrage about these figures? These are appalling figures. and yet they are true. The median age in Kenya is 20. The median age in Malawi is 18. HIV has caused a lot of deaths, of course. Not all by any means. Right, more possible explanations. Now, given that the data so far is largely from African cities, the numbers may go higher. So the infection fatality rate may go higher when we get when the pandemic spreads into more rural areas. Because what happens is younger people move into the cities for work and leave the older people at home. So the rural areas have a higher average age than the cities. So we could see some increase, but I don't think it's going to be enough to explain the differences we're seeing already. Now, another idea, Africans have had exposure to other coronaviruses already, therefore have cross-immunity. So it could be that if you've been exposed to one type of coronavirus, you are partly immune to this novel coronavirus. It is a novel coronavirus, but it's still a coronavirus. This is called cross-immunity. So that's one possibility. There could be a lot of circulating coronaviruses, perhaps causing asymptomatic infection, perhaps just causing the common cold in Africa compared to the UK. But there again, in the UK, we have 4 coronaviruses cause a fair proportion of common colds anyway. So we do have that in the UK. So are there other coronaviruses circulating in Africa that we don't know about? Because only the only coronaviruses I know about are the 4 that cause common cold, SARS-1, MERS, and the SARS coronavirus 2 that we have now. I don't know of any others. 4, 5, 6, 7. That's all I know of. Are there other types in Africa that haven't been identified? Possibly. Other coronaviruses is a possibility. Regular exposure to malaria and other infectious diseases. Now, I have postulated in the past that these other infectious diseases might predispose towards more severe COVID-19 infection. And the reason I said that was we know that people who have influenza and COVID-19 at the same time didn't do very well in the last influenza season in Europe and in America. But it looks like the opposite may be the case. It looks like regular exposure to malaria and dengue and all the other infectious diseases that are so prevalent in Africa may be offering some degree of cross-immunity or have somehow invigorated the immune systems to make them more responsive to this novel antigen, to this novel coronavirus. So that's possible. That's another possibility. So previous experience fighting other infections. Is there a genetic factor that protects the Kenyan population from severe disease? Well, if it is, it's affecting the Malawi population and the Cameroon population. And the thing about genetics in Africa is African populations are genetically very diverse. So the population in Mozambique, Kenya and Cameroon can be very genetically diverse. I mean, you can get 2 people groups in Africa that are just a few hundred miles apart, perhaps separated by a mountain range, and they haven't interbred for maybe 15, 20,000 years. And they are actually more genetically different from each other than maybe I am from someone in India or even someone in China. So Africa is a very genetically diverse country. So if there is a genetic factor there, it's one that's shared by very diverse genetic people groups. Possible. Another possibility is there a different virus? Is there a mutated strain of the virus in Africa that is less virulent? Well, that doesn't seem to be the case. Now, we know that there's different strains of the virus. We know that there's been many genetic mutations in the virus, but overall they don't seem to be massively affecting morbidity and mortality. So I don't think it's a different virus. Now, another thing that of course springs to mind is vitamin D. Because of course these are sunny places. And a lot of Kenyans work outside. A lot of people in Mozambique and Malawi work outside. But there again, many don't work outside. So are they producing more vitamin D? The dark skin will produce the vitamin D more slowly, but with more sun exposure, they'll produce plenty of vitamin D. Is vitamin D a factor? Whereas in the West, we don't get enough vitamin D typically. Well, I think it is a factor, but it doesn't explain the difference between Kenya and South Africa, because South Africa's sunny as well. So it could be a factor. So we might end up with many, many different factors that are explaining this pretty wonderful reduction in death rate that we're seeing so far. So from that, you'll conclude that I don't know why the death rate is so low. They're just a few things that are possibilities. Now, Research Institute for Development from France, they're going to test thousands for antibodies in Guinea, Senegal, Benin, these African countries, all over the place. I think some others I haven't mentioned there as well. So again, this is going to be an international collaboration, testing for antibodies in many of these African countries. And their results will be out in... This is a very large-scale study. The results will be out in October. So we'll know much more then. Given what I know now, I would predict that there would be a high seroprevalence in these African countries, but there would be a low number of people getting sick, a low number of people being hospitalised, and a low number of people dying. Having said that, we don't know, and we should always prepare for the worst case scenario. So the health systems in these countries should be massively reinforced in case it turns out I'm wrong. So in your city, in my city, if you live in the UK, we've got Nightingale hospitals. We've got a huge Nightingale hospital where I live. Lots of us were scheduled to work in it. Thankfully, so far, it hasn't been needed. But better that it was there and not needed than not there at all. So I'm not saying we don't need to prepare in Africa. We do. I'm not saying we don't need to do all these things. We do. We need all the public health measures. We need all the preparation we can get. But given what I know so far, I would be optimistic. And I really hope that hypothesis is substantiated. Now, implications. It means Africa is on its way to herd immunity with very low levels of morbidity and mortality. But it also means because there's so much virus present in the community, vulnerable people must shield. That becomes even more important. So where does this leave us? Well, the pandemic ploughs on its fatal path in Western countries and the United States. And indeed, South America seems to have appallingly high death rates. South Africa seems to have high death rates, but other countries in sub-Saharan Africa, genuinely, people don't seem to get sick, don't seem to be as hospitalised, and don't seem to die at anything like the rate, and perhaps hundreds of times less than in Western countries. And we really need to find out why, because if we could find out why, we could apply that finding to Western countries and potentially save a lot of lives. But at the same time, we have to carry on supporting African situations as much as we can, because it may turn out that they do get a lot more deaths than this provisional data would suggest. So we have to be ready for all contingencies. Quite a few people have commented I'm not very good at ending videos, and of course you're right. I can seem to manage the introductions okay, but the conclusions I'm appalling, so apologies for that. As we conclude this video, thank you for watching.